What's up, y'all? It's midnight here in Fort Myers. I just had my third coffee for the day. Let's talk surgical extractions, bone graft, implants, everything oral surgery. I'm super excited to show you this case because I learned a lot and I know you can too. All right, let's cut the intro short. I got a patient that presented with a tooth with a periapical radiolucency. Treatment plan was surgical extraction, bone graft, membrane, and future implant placement. If you guys know anything about dentistry, implants are the hot topic and you gotta know how to take teeth out and graft the sites properly to make sure you have a nice ridge to place that implant in later. Now, I did this case just a few months after graduation from dental school, so there's definitely mistakes I've made along the way, but I've been able to learn from these mistakes and hopefully you won't make the same mistakes after watching this video. And make sure you stick around till the end, as I'll be discussing the valuable feedback I received from my periodontist mentor regarding my technique after I showed her this case. And trust me, there is so much to learn from this case, you don't want to miss a specialist perspective on this. And let's jump right into it. All right, first and foremost, woo! Red flag immediately when examining this type of extraction case. This tooth has undergone root canal treatment. So after doing a couple of these, you know these extractions aren't always the easiest and most predictable. Typically, a root canal treated tooth becomes hollowed out and brittle, making it more prone to fracture during extraction. Additionally, I carefully observed the curvature of the roots. I observed that mesial root, it was angulated more distally. Conversely, that distal root right there presents a more straightforward configuration. I noticed that the curvature of the tooth doesn't allow for a straight path for the tooth's exit. Therefore, it became more evident that some bone removal may likely be necessary, as this tooth may break in the bone. To accomplish this, I'm anticipating that I'll need to use a surgical handpiece to fully get the tooth out. Now, let's discuss my approach to the extraction process. Firstly, I prefer to flap the gums out of the way. This involves lifting the gingival tissue with the periosteal elevator. And if I'm gonna use a particulate bone graft and membrane like I do in this case, I'm gonna use a 15 blade to incise the gingiva to create enough separation from the gingiva from the bone so I can place those materials properly. And starting on the buccal side, I make an incision slightly distal to the extraction site and then extend that incision mesially. And to ensure proper visibility and minimize bleeding, I like to use the sharp edge of the periosteal elevator. I've noticed using the rounded end sometimes requires me to use more force and I don't get a clean lift off the bone. So by gently manipulating the sharp end of the periosteal elevator against the bone, I gradually peel back the gingiva by applying firm pressure on the bone, allowing the flap to open wider. And the last thing we want to do is be forced to drill with the surgical handpiece and have to fight the gums the entire time. Now, upon reviewing the photos of the extraction site, I noticed a few areas where I could have improved. Firstly, the flap design is far from ideal. When navigating around that second molar in the back, I didn't properly make contact with the bone. Instead, I was slightly above it, almost like poking my way through instead of making that nice clean cut all the way down to the bone. This approach caused damage to the papilla, which appears to be compromised in that area. Guys, I can't stress this enough, but proper flap design is essential for grafting. Okay, so here's the extraction site, but how did this tooth even come out? Now let's discuss the steps of the surgical extraction, as it didn't really go as planned. To begin, after periosteal elevation, I used the 15 blade to create more separation so I can see the delineation between the tooth and bone. Next, I used my favorite oral surgery tool of all time. You already know what it is if you've been following me. It's that Carl Schumacher approximator to loosen the tooth up from the bone, creating space for elevators and forceps to work the tooth out eventually. Gradually, I expanded and widened that PDL space, or that periodontal ligament space. Then I used this golden luxator to access the tooth as apical as possible. Although the tooth exhibited slight mobility, I exercised caution and avoided applying excessive forces, thinking, wait a minute, it's a root canal treated tooth. This tooth might actually break on me. And guys, you can always get a great feeling of how locked in that tooth is in the bone just by gently applying some forceps on it and feeling it out. You gotta listen to those teeth when they're talking to you. But if this is hard for you right now, don't worry. This intuition comes with practice, so never force anything. But I like to use the forceps a little earlier than usual, just to shock that PDL and loosen everything up to start. And this step early on ensures that if the root were to ever fracture, that PDL has already been loosened up all the way down the tooth. And then I know that the root tip has already been previously mobile. If a root tip is completely fused into the bone, we got some work to do. So the forceps I'm using are the 23 forceps, the holy grail of lower molar extraction tools, the cow horn. This is a fantastic tool because it really digs its beaks into the furcation, and with a gentle pumping motion up and down in the sagittal plane, it facilitates a smooth removal by lifting the tooth just out of the socket gently. So as I proceeded to pump up and down, porcelain crown pops off. And this outcome was to be expected, since even a little bit of pressure with the forceps gives a tremendous amount of pressure to the tooth. You don't believe me? Try putting your finger in the forceps and lightly squeezing the handle with the other hand. You'll instantly know what I mean. Anyways, the crown pops off. I'm still using the cow horn because I still have access to the furcation with it. But to my surprise, the tooth eventually comes out. So I have the tooth in my hand. I'm always looking at the tooth and its apices to make sure we got the entire tooth out. It's very important to examine that. And as I check it, I realize that the mesial root tip stayed in the bone. But with a good preoperative assessment, this should be anticipated based on the deflection of the root. Now what are we gonna do? Simple. First thing to do is just smash that like button to help the YouTube algorithm. It helps other people see these videos, and it helps me understand what kind of content you guys like. Just close up the surgical site and refer the patient out to a periodontist, right? No! Don't worry. When you do enough of these cases, you simply know the next logical course of action to take to get the remaining portion of the tooth out. In such situations where a lower molar root tip breaks in an open socket, my preferred instrument of choice is a wonderful tool called the East-West. I was able to use this instrument to access the mesial side of the canal, which curves distally. By strategically positioning the East-West instrument, I gently applied pressure trying to move the root tip towards the space we created, towards the furcal bone. And repeating this action a few times, I gradually expanded the socket. After attempting to extract the root tip with the East-West and other tools, I didn't have any luck. Therefore, the next step is to carefully evaluate the proximity to the inferior alveolar nerve and see if using a surgical handpiece would be a safe option here. Proceeding with caution, I drilled away at that furcal bone to create more space for the tooth root to exit. And guys, I'm definitely avoiding drilling on the buccal or lingual side here. As we know through the research, if we are losing buccal bone, we're losing that oh so precious keratinized tissue needed for proper implant placement. And that furcal bone is less essential as it'll be replaced by new bone formation over time. So I created a small trough within the furcation, allowing that mesial root to successfully be extracted with the use of the East-West. All right. Tooth's out. Tough extraction, but we still gotta graft, place membrane, and smash that like button so other people can learn with us. Anyways, I used the periosteal elevator to widen the flap more so I could insert a non-resorbable membrane that had been cut to an appropriate thickness and length. I believe I mistakenly used a resorbable membrane here, as pointed out by my mentor. Oops. At least I'll never make that mistake again. Here, I employed the lingual tuck technique by placing that membrane in the lingual flap first with the rounded end of the periosteal. Then with my thumb on the gingiva, I release all the tools, ensuring that the membrane remains upright on the lingual side, covering the graft site. Next, I proceed to place 50-50 corticocancellous graft material. Carefully, I scooped small amounts of the graft and placed it delicately into the surgical site, ensuring not to pack it too tightly. I prefer a light packing method rather than it being excessively tight. And to achieve optimal coverage and bone retention, it's often more effective to place the membrane first and the graft second. And this approach creates a nice tenting effect inside the graft and shields it with the membrane. Thus, I generously position the graft material, mixing the corticocancellous graft with a small amount of blood. All right, at this stage, we have the graft material in place, covered by the membrane. So the next step involves tucking that membrane into the buccal area. To do this, I use a periosteal or even a spoon. And if needed, I would use the college pliers to grip the gingiva and use the spoon to help tuck the membrane into the buccal securely. Now, let's talk suture design for bone graft and membrane placement. My preferred approach is to utilize a horizontal mattress suture to bring the flaps closer together, aiming for proper flap approximation. It's important to note that we don't want the flap to be completely sealed shut. We want it to have the ability to breathe a bit. To execute this technique, I began by entering the mesiobuccal area, passing it through the mesiolingual side in a straight path. Next, I move to the distal lingual area and bring the suture over to the distal buccal side, suturing on the buccal aspect. This approach allows for nice approximation, effectively sinking the graft and membrane deeper while closing the buccal and lingual flaps. And then I threw a figure 8 suture on top of the horizontal mattress to secure it firmly in place for optimal healing and integration of the graft material. But this creates a nice X-shaped pattern crossing over and effectively locking that graft in place. And this technique ensures a stable and secure environment for future implant placement and also promotes a healthy site for successful healing. The patient will return in 3 weeks for suture and membrane removal. And in a few months, we will proceed with the implant placement to restore the patient's masticatory function with a nice healthy tooth. What a beautiful case. But like I promised, let's talk about my periodontist mentor's feedback on how we can perform a cleaner surgery with the higher clinical prognosis next time. She starts by saying the main ideas while preparing an envelope flap. Number 1, when preparing an envelope flap on the buccal, start at the distal buccal line angle, keeping your blade in the sulcus until you reach the papilla on the mesial of the tooth you started on. And when you have reached the papilla, turn your blade to keep it in the sulcus and divide that papilla into buccal and lingual parts, allowing the buccal portion of the papilla to be included in the buccal flap. Keep your blade in the sulcus and head towards the mesio-buccal line angle of the tooth mesial to your tooth extraction. And she says if you need more visibility at this point, you can easily add releasing incisions going outward from the distal line angle of the distal tooth and the mesial line angle of the mesial tooth. She goes on to say, while reflecting the flap, keep the concave and sharp side of the instrument on the bone, while keeping the convex side of the instrument towards the soft tissue. Doing this slowly and gently minimizes the risk of tearing the flap, which will make suturing easier since you won't have tears. Minimizing the tears to the flap will also help speed the healing process and make your healing more predictable. Then she gives me feedback to how I pack the graft into the site. She says pack the bone to the level of the crest. Overpacking the bone above the crest will not give you any advantage here, Akash, and the bone above the crest will not be retained. The non-resorbable membrane will be the membrane you leave exposed to the oral environment, not the resorbable one. So that was my mistake we talked about earlier. Next, we talk about my suture choice. She says if you like to use PTFE sutures, use them. If you don't like them, use any other suture you do like that will keep its tensile strength for about a month. You're not gonna leave them in there for a month, but you need them to retain their strength. Next, she begins to comment on the way I did the suturing. She comments by saying, try taking bites of the flap with the sutures that are a little deeper, giving you a little more space between your needle entry point and the edge of the flap. This one I've definitely noticed in my clinical practice when there's very little space between the entry point of the needle and the flap. Those sutures come off really quickly. And within a couple days, patient comes back saying, oh, those things were dissolvable, right? I'm like, oh, they should have been there for at least a couple days. I'm like, no, just in a day or so it came out. I'm like, oh, well, okay. And the papilla aren't closed properly either. Place interrupted sutures to close the papilla that you incised. So after using the 15 blade to incise, elevate the papilla off first with the periosteal and then try to reflect the flap with the periosteum attached. And here she lays out the numbers for me on the flap on how to create a smoother, cleaner flap. Wow, I am so appreciative of my mentor for being able to dissect my case like that and offer me so much wisdom. It really means the world. If you don't have a mentor like that, please find one because there are tons of people in the community that are willing to help. And to wrap things up, I wanted to share this case with all of you because it has been a tremendous learning experience for me. I strongly believe in the importance of making dental education free and accessible to everybody around the world. You know, it's really disheartening to me that dental school nowadays is so expensive, yet fails to provide comprehensive knowledge, leaving us to invest in expensive post-graduation courses just to truly learn. Did I make mistakes during this case? I most certainly did, as we all do. However, it's essential to share cases with our peers and seek help and tap into that caring dental community. Trust me when I say this, that there are wonderful individuals out there who offer valuable support and advice. Learning from our mistakes is key to preventing them from reoccurring in the future. And by sharing my own mistakes, I hope to help you improve on your own techniques. So in summary, we discussed a challenging surgical extraction involving a root canal treated molar, assessing radiographs for case difficulty, the instruments and drilling techniques used, proper flap design, graft and membrane placement, suture techniques, and how to correct mistakes when viewed through a specialist perspective. I'm sure that there are individuals out there charging a ton of money to recent graduates drowning in debt just to learn the level of surgical technique I showed you today. And if you've made it this far into the video, I kindly ask that you please give it a thumbs up, subscribe to my channel, and share this video with a friend of yours. It's been truly a pleasure sharing this journey with all of you. This is Dr. Rana signing off.